Good evening, everyone. So today our lecture is spondylolisthesis, and it will be taken by none other than Dr. Sanjay Dhar, sir. He's a renowned faculty, doesn't need any introduction, and an excellent surgeon as well. So let's hear it from Sanjay Dhar.
Thank you, Agni. So I have the privilege of speaking on spondylolisthesis. It will be a long lecture. Hopefully, I will try to cover up most of the relevant things. Of course, there may be many other things which I may miss, but I'll try to do as much justice as possible. So spondylolisthesis, as you know, spondylus is spine and olisthesis is slipping. So spondylolisthesis is whenever the spine is slipping from its normal alignment, where usually it is around L5, S1, or it may be other common site is L4, 5. So this, whenever the spine is slipping forwards, it's called as spondylolisthesis. Sometimes it may slip a little backwards, so then it's called as retrolisthesis. So we'll be talking about spondylolisthesis today. So let's first take a typical vertebra. As you know, this is for the students. A typical lumbar vertebra, it has a vertebral body. It has the pedicle. I'm sure all of you, particularly the PG students, they should have full knowledge of these bony landmarks, both as a surface landmark or also on the radiology. If you miss my sound, please tell me, because I'm on AirPods, so battery may sometimes go low, so I will not realize. So just remind me if the sound is less or more.
It is okay right now, sir.
Okay, so coming to the vertebra, as I told you, PG students, they must know the moment you are shown an X-ray of a spine, first thing most important for a student is that you should be able to identify all the relevant anatomy, both as well as X-ray, as well as on a model if you're given a vertebra. So just to revise the whole thing, this is the transverse process, this is the pedicle, this is the facet, and the pointed margin of the facet is called as mammillary process. It's an important landmark when we think of doing a pedicle screw fixation. So mammillary process is an important landmark. So superior articular process, then there will be an inferior articular process. This is an accessory process here, and this is the spinous process, and this is the canal. So in a lumbar vertebra, you have a very wide pedicle, and the area between this, the pedicle where it ends, the confluence of the spinous process and the lamina, this is called as pars interarticularis. And this is a very important landmark as far as spondylolisthesis is concerned. So this area, sometimes if you come here, again, you can see this is the link. This is the link in the chain. So between the posterior elements and the anterior elements, something which is as if it is clasping it, that is the pars interarticularis. So above it is the superior articular surface, below it is the inferior articular surface. This is the lamina, the butterfly shape. The whole lamina is there, and the confluence where the whole thing meets all these bony landmarks from the anterior column, the posterior column, and the middle column, they join. That is called as a pars interarticularis. It's a very important landmark and an area which is under a lot of stress. Whenever there is movement of the spine, this area is under a lot of stress. So again, if you come somewhere here, it will be pars interarticularis. So that is what you should remember. And as I told you, always you should be able to identify these bony landmarks, and this area, whenever you are talking of spondylolisthesis, this becomes a very important landmark. So key component in the segmental integrity, as I told you. So you can see it here, the confluence. And whenever there's a break, it's an important predisposition towards the listhesis. So it starts moving forward. So the clasp, the chain, which is held together between the two columns, once it is broken or it is loose, it is lytic, then it starts loosening up, and finally it may start shifting forward. So this is the greatest force. As I told you, in flexion, extension movement, there is a lot of stress on this area, this link, because that is the two holding together. So whenever you are hyperextending, there is a stress on that. Whenever you are flexing, the body moves forward, so there will be stress on that. So this is more or less the weakest part of the neural arch. Pedicle, the column, middle column is the strongest part, while just adjacent to that is the weakest part. So this is the area which actually starts causing problems. So a little bit, although this topic is not about spondylolysis, but for the continuity of the whole lecture, you need to know spondylolysis. So whenever there's a defect in the pars, it is not broken completely, it is not loose completely, it is just a lytic area there, it's a weak area there, it is called as spondylolysis. So not associated, it generally is not associated with a slip. So when it is called lysis, it is just a weak area. When it is listhesis, it means it is started shifting there. So when it has started moving, it will be labeled as listhesis. So it is most commonly in adolescents, people who are hyperextending like bowlers, game players, who do a lot of hyperextension, they will start getting this lysis. Or it may be even developmentally present there as a weak area. Okay, so pars defect, it is present very commonly. It may be asymptomatic. You may not realize it whole life. You may notice it on a sudden X-ray of the spine where there is a lesion, which is a lytic area. It may not be associated with any listhesis. Most of the times, it is present in almost 4 to 5% of population. Older days, we used to, it was very difficult to see these on a plain radiograph. We used to do radioisotope scanning, single photon emission tomography, where we could detect this area where there is a less uptake area. If it is a chronic lesion, if it is an active area, it will be a high uptake area. So that is how you detect and diagnose it as an active lysis or an inactive or a chronic lesion. So SPECT scan, or now we have MRI very easily available. So SPECT scan, we don't do as much as we do an MRI, where you can pick it up as an area of high activity, where there is some signal changes there. You can pick it up as an active spondylolysis. So SPECT scan will show an uptick, as I told you, in a very active lesion, which is painful, active, like, or a recent injury. You might pick it up as on the scan, or you might pick it up as in bone marrow edema with an MRI. So coming to classification of spondylolisthesis. So that was spondylolysis. Now let us go directly to the spondylolisthesis, where there is a proper shift of the L5 vertebra or an L4 vertebra on L5. As we are talking, usually the conventional and the typical listhesis is in L5-S1 area. So classifying that, we'll say Newman and MacNab, they have classified it into different, like dysplastic, isthmic, degenerative, traumatic, pathological, and iatrogenic is when it is post-surgery or some physician created. So generally, the presentation-wise, they are only dysplastic, isthmic, degenerative, traumatic, and pathological. So coming to then, as far as mechanism, hello? Huh? Hello, okay.
There is some disturbance, muted, sir.
Okay, okay. So as far as mechanical classification is concerned, where how much shift is present, you classify it by Meyerding classification, which grades into 0, where there is no slip. There may be lysis, there may not be lysis, or in degenerative, there may not be lysis, but there is 0 slip, no slip, it's called 0. Then 1 is when 1/4, if you divide the sacral and plate into 4 parts. So if it is 1/4 or 25%, it is grade 1. Around 25 to 50, it is grade 2. More than 50 to 75, grade 3. Then grade 4 is almost touching the anterior ledge of the sacrum. And then 5 is spondyloptosis, and there is a total disconnect between the sacrum and the L5 vertebra. So it is called as spondyloptosis. So coming back to Wiltse classification, type 1, as I told you, is dysplastic. When there is an existing defect present developmentally, it slowly starts shifting. It is called as dysplastic. Then type 2 or isthmic is when there is a pars, there is a fibrous tissue in the pars. So it is type 2A, or it is a fatigue fracture like thing. Then 2 is when the pars is elongated. There is no fracture, but there is an elongation of the pars. So you can see this profile. This is like a dog. So if you see later on an X-ray, I will tell you probably on the X-ray. So this is like the collar of the dog. So this is when there is a elongation of the collar. This starts elongating and it starts shifting. So this is called as type 2B. When we have microfractures, there is no definite fracture there. It is called as 2B. And when there is a fracture, acute fracture of the pars, it may be traumatic. It may be a full-fledged lysis there with shift. It's called as type 2C. So fibrous tissue, elongated pars, and acute fracture of the pars, type 2A, 2B, and 2C. So it is, you may just remember isthmic. So when there is a pars defect, and dysplastic is when there is an existing shift, it is in a developmental this. Then coming to type 3, which is type 3 is what is that? You can see here degenerative. That is not present with any lysis. So it is in old geriatric patients where over a period of degeneration they start shifting. There is no defect, so there is facetal widening. So they start, the facets start loosening up, and then though there is old shift. Usually it is not more than grade 2. In a degenerative, you will not see beyond grade 2. You will not see a complete dissociation as you will see in this or in dysplastic type. Then type 4 is traumatic injury. When there is an injury, you will see pedicle fracture. Not very common, very uncommon, particularly in the lumbar vertebra. In cervical, you might see it more often than in lumbar. So it is traumatic. Then type 5 is when it is pathological. There is any lesion, suppose there is a mets or something in the area which starts failing the pedicle and these parts, interarticularis and pedicles, because usually they metastasis and they start around this area only. So there is weakening of the pedicle and then the shifting starts. So it is associated with any pathological. That is type 5. So this is how you classify. This is a very famous classification, Wiltse's classification. There are many other classifications, but let us not focus on them. Even clinically also, we don't bother about all the classifications. We just know the meriting classification, how much shift, because for audit purposes, you should know that whether it is type 1, type 2, type 3, so that the results can be sort of quantified in that manner. Or it is whether it is dysplastic, isthmic. And so we have a very broad category of isthmic listhesis and degenerative. These are the two common types. Rest are not so common. So that is what you need to remember. So coming to individual dysplastic listhesis, as I told you, there is defect in the formation of part of the pedicle. There will be abnormal pedicles as well as the facets, which allows slip. This is a condition which is born with. So it is a congenital condition, as I told you. There is a defect in the posterior elements. So you might see them from the very beginning. So these are ones which are they can be of high grade. You can even see a spondyloptosis coming to you who has basically a congenital defect. So usually, as I told you, degenerative, you don't see such high grade of listhesis. So coming to dysplastic, the more common types, these are type 1, as I told you, is when there is a fatigue fracture of the pars. So these are exclusively at L5, LS junction, abnormalities of upper sacral surface. There may be dome-shaped sacral promontory. So there is a shape of the sacral promontory is not abnormal. There will be neural or the neural arch of the last mobile vertebra. So there will be some neural arch deficiencies. Spina bifida is common, and abnormal facet joints. So these are dysplastic ones. So then as it progresses, there may be elongation of this. So there is fibrocartilage formation. So it keeps on elongating over a period of time. So then they start deteriorating. So it may progress from grade 1 to grade 2 and grade 3 like that. So it may come, and with when there is fibrocartilage proliferation in the pars area, because the body tries to sort of stabilize it by forming more fibrocartilage tissue. That is why in listhesis of dysplastic types, you will see a lot of canal stenosis, foraminal stenosis because of the proliferation of the fibrocartilage there. So which is not very common in degenerative types. So you'll see the neurodeficit in these dysplastic types, spondylolisthesis more often. There will be a lot of canal stenosis. There will be even central canal stenosis in such cases. While in degenerative ones, you will not see very common central canal stenosis. You will see more lateral recess stenosis because of the foraminal narrowing. So type 2, as I told you, abnormalities of the pars, repetitive fractures of the pars. usually only spondylolysis. As I told, they are elongated ones. The pars starts elongated. So slip is usually low grade and it keeps progressing very slowly. So Isthmic, again type A, type 2 that I have already told you. So coming to type 3, which is degenerative spondylolisthesis, there is lesion of the facet joint. As I told you, there will be degenerative developing of the facet joint joints. So there is elongation, there is initially there may be synovitis, then widening of the facet joint. So slowly they start giving way, and then aging abnormalities, abnormal movements, and so remodeling keeps on happening there also. So there is progression of this disease. So it is a degenerative. There is no defect in the pars as such. So it is a degenerative thing which progresses. Again, as I told you, it will not be very high grade. It will be grade 1 or grade 2 most of the time. So usually does not exceed 30%. Subluxation halted when the isthmus or the inferior articular process abuts at the upper margin of the lower vertebra. So there is a mechanical blockage of the listhesis. So it won't go beyond grade 2. So most often at L4 and 5. Because L5 S1 is a very stable area as compared. There is most of the mobility occurs at L4 5. It is so L5 S1 it is protected by the iliac wing. So there is a lot of structural stability provided by the pelvis. So motion occurs more at L4 5. So degeneration, once there is hyperlordosis or kyphosis, they start moving at L4 5. So that is why in degenerative you will see it more often at L4 and 5 rather L5 and L5 S1, there will be settling of the disc spaces. So there will be hypermobility at L4, 5. So there is more common chances of listhesis at L4, 5. Then coming to traumatic, as I told you, it is because of any fracture of the bony hook of the dorsal element that does not involve the pars. There may be facet fracture or there may be pars pedicle fracture occurring there. Occurs weeks or months after the injury. And slip acute fracture. So these are acute fractures. So there will be sudden subluxation. It will start moving around. So you will see it in fractures also. So it may be present in higher levels also. So as the canal is very wide, so it may heal by simple immobilization. But understanding the present biomechanics, things have, in olden days we used to many times used to preserve these. If there is only a pars fracture or a pedicle fracture or posterior element fracture. So, but now because knowing the 3-column concept, we tend to sort of fix most of these also because there is not to allow surgical stabilization. So pathological spondylolisthesis is a separate topic. It will be associated with secondary, maybe secondaries or a primary tumor, giant cell tumor in the posterior elements. So there is alteration in the bone structure there and inability of the bony hook to maintain it. As I told you, there's a clasping-like mechanism which holds the posterior elements and the anterior elements together. So when there is any weakness in this bony clasp or the bony hook, so there will be listhesis in such cases. So this is type 5 pathological spondylolisthesis. So 2 types again, it will be generalized, part of a generalized disease like Paget's disease, hyperthyroidism, osteoporosis, where there will be sort of fatigue fractures or even part of any compression fractures, or it will be local, as I told you, giant cell tumors, localized infection or a destructive process which can lead to pathological spondylolisthesis. These are most difficult to treat. Therapy is directed at underlying because you have to treat the basic cause, where suppose you have a giant cell tumor, so you may need to treat the cause first. So fixation hold is very poor, so stabilization becomes very difficult. So you have to go to the higher levels, and then you don't have any local hold because your pedicle is very adjacent to it, so you will not be able to get a hold into that. And healing is not there, so you have to depend on your implant, as we generally have. It's the race between union and implant failure. So if you don't have local signs of healing, you are dependent on the fixation above and below. So difficult thing to manage. So same thing can happen in Apollo. 1 minute, can we go? We have good old days, we used to do a lot of laminectomy. So we used to go as we go laterally. So there was sparse failure later. So they would have iatrogenic failure. So they would subsequently come with recurrence of symptoms because the slip starts. So they have mechanical failure because of post-operative surgery. So then finally, spondyloptosis, as I told you, when there is complete disconnect between L5 or S1 or the upper vertebra or the lower vertebra, it is more than 100%. The L5 body, as you can see in this, it is lying in front of the sacral. There is rounding of the sacral dome. Because of the repeated movement there, there is trapezoidal shape of the vertebra, and the sacral dome becomes rounded. So this is spondyloptosis, and there is no connect between the two. There is a fibrous tissue interposition, and there is a lot of buckling of the canal. So they have a lot of stretch on the roots. So they get a lot of canal stenosis symptoms. They have mechanically they are very unstable. So that's called as spondyloptosis. So coming to symptoms, typical clinical symptoms will be low back pain. Most of them will have backache, mechanical back pain. Initially, in degenerative grade 1, you may have only backache, or if there is a lot of facial hypertrophy with lateral recess stenosis, they will get a lot of radicular pain. But usually in higher grades, you will have a lot of backache and mechanical instability. So stiffness with hamstring shock. As there is change in the pelvic tilt, there will be a lot of hamstring tightness. So they will walk with like a simian gait. They'll walk like gorillas. They will have your knees. They will be in flexion in high grade listhesis. As you go beyond 3 and 4, they might have a lot of hamstring shortening and spasm. So lumbar compensatory hyperlordosis is in the lumbar area, and they walk with flexed hip and knee gait, simian gait. And radiation of the pain below the knees or caudal syndrome may be seen in high-grade patients, or where there is a lot of central canal stenosis, particularly in high-grade isthmic types, and even in pathological ones, you can see central canal stenosis, caudal syndrome. So pain, as I told you, is the primary presentation. It may be backache. It will be a steady type of ache, or related to position or posture. Ligamentous strain. They might have some dull ache while standing for a long time, particularly these obese ladies who stand in the kitchen for long duration. They will have a lot of backache. They are not able to stand beyond a particular time. They need to sit every 15-20 minutes. So they have a lot of backache elements. So then, in some cases, there will be radicular presentation where chronic nerve, because as I told you, fibrocartilaginous proliferation at this pseudoarthritic area, they will start getting root stenosis, root compression, and they will present with radicular pain. Spinal stenosis, common in degenerative listhesis, relief with extension reduction in slip. When they stand erect, there is mild reduction in slip, so they might get some relief. Women are more likely to be symptomatic. Women 5 times more likely to develop degenerative slip. So this is the step off. As I told you, in high-grade listhesis, there is hyperlordosis above. You will see a lot of valley-like thing in the whole area. You can sort of insinuate your hand above the spinous process. You can see this is basically called a step off. So neuro examination usually normal. They may not initially present with neuro deficit, but they will start getting stenotic pain, lumbar canal. As they walk, they will start getting leg pains. Initially, they may not have any pain. So step off, as I told you, high grade is common in dysplastic and isthmic types. So that is why you see this step off. In degenerative, you may not see this step off unless it is a above grade 2 listhesis. So tight hamstring syndrome, as I told you, once there is high grade, there is hyperlordosis. So pelvis is tilted. So you have hamstrings which become tight, and it is seen in younger patients, active, hyperactive patients, stoop posture, and walking with flexion at hips and knees. They have waddling gait, and isthmic and dysplastic, they see increased lumbar lordosis. So as the grade is higher, you will see increased lumbar lordosis in them. So isthmic, coming to isthmic, the low backache is usually predominant symptom. Some patients experience leg pain due to nerve pinching, as I told you. The leg pain will generally be worse than the patient stands or walks, and it is almost always the L5 nerve root. So usually 2 nerve roots will be affected, the traversing root. So depending on the amount of slip and if there is hypertrophy of the parts, we will see a lot of fibrocartilaginous hypertrophy, whether the exiting nerve root or the traversing root. So you will have both L4, L5 on L4. At L4 junction, you will see L4, L5 deficit. Here you might see L5 and S1 deficit, depending on the amount of mobility at that area. A few slides again about the lysis, about the symptoms. They usually, as I told you, they are athletes, lower back pain with or without a traumatic event, hyperextending sports where there's a lot of hyperextension, like bowler making the last final step when you have hyperextension ball. So you do even in listhesis, if you do it's one good test. So you ask them to stand on one leg and then hyperextend, you will get pain, which is test. It is even in listhesis, if you try this is one simple step. Ask them to stand up on a single leg and try to hyperextend, they will get pain. So as I told you, lysis defects are very difficult to see on a normal X-ray. You might need either a scan or an MRI to get this diagnosis. So generally, with sclerosis and surrounding bones, you may not be able to see this defect. But there are radiological views where you can try to find out the defect. So diagnosis, how do you do diagnosis? Listhesis is diagnosed readily on plain radio. If there is a grade 1, grade 2 listhesis, you can easily see it because the anterior sacral ridge margin, and if you draw a line between the anterior border of this L5 on anterior border of the L1, they should be in a smooth single continuous curve. If there is any step off, that means there is a listhesis. So this is on a plain X-ray, preferably a standing X-ray. You should do this. So what is preferred is called as erect radiographs, or we call also as stoop views, where we make them sit and then bend forwards. And preferably you should also get the hip joints in this, because you see the for prognosticating the whole thing. We'll talk about that later, whether you should be able to see the pelvic tilt and pelvic incidence in these cases so that we know the prognosis. And it will tell you a lot about the adjacent segments also. So AP view, lateral view, dynamic radiographs, flexion extension view. So any suspect, in fact, any degenerative spine which is presenting with radicular pain and backache, you should always do flexion extension views on lateral. It's called as dynamic radiographs. Then MRI and CT. Usually MRI, CT we do in specific indications where like spondylolysis or even in defects where we want to see, but more often we do MRI and plain these radiographs. Occasionally SPECT or discography, but not a very common unless you are suspecting you are not able to pick up. There's a lot of pain, young athletes, adolescents, you are not able to pick up any lesion there, yet you are strongly doubtful about the diagnosis of spondylolysis, then you may do a SPECT scan. Discography, very rare, again, as it is a functional element is present there. So you just to provoke a test, you can do discography where you inject the dye into the disc. Very rarely done these days because MRI, we have good MRI pictures and we can. So flexion extension views, as I told you, is a very important tool in diagnosing these, particularly where there are grade 1 and in grade 1 indications, and also to detect the adjacent segment disease. Suppose you have an L5 S1 listhesis, to see the integrity of the L4-5, you need to do the flexion extension views. So whenever there is more than 10-degree opening, so you draw lines on the inferior border and the superior border and see the open amount of opening. If it is more than 10 degrees, or if there is motion of around 4 millimeters from the anterior line. So if the tip, the difference is more than 4 millimeters, that means there is a listhesis present. So this is a very important tool. As I told you, you should do You can do on the table bending films, or you can do erect films, or you can do stoop views where you ask them to stoop forward and take these X-rays. Basically, these are revealing the instability. If there is grade 1, if it is grade 2, it is easily picked up, but you want to sort of see the amount of, many people have just backache and they have no radicular pain, and you want to prove that this is the cause of it. So if there is any amount of mobility there, maybe some listhesis which is stabilized. So to provoke that, to get that revealed, you need to do bending film. So if there is motion there, which is more than 10 degrees, more than 4 millimeters translation, then it's a symptomatic area. So that might be the reason cause for. So you may need to stabilize it. So it is a tool to plan the treatment as well as sort of provoke. So this is how you draw it. So every degenerative backache and where you should do flexion extension views. It is very important for PGs to know that. So bending views, as I told you. Then coming to, as I told you, you should take hip along. We took the whole pelvis views. Basically, these are, so this is pelvic incidence. So sacral slope, see the center of the femoral head and draw perpendicular on the sacral center of the sacrum. And this angle, this is called as pelvic incidence. And similarly, pelvic tilt is the vertical drawn from the femoral head and to the center of the sacral plate. So this angle is called as pelvic tilt. And then there is something called as sacral slope. So how much slope, this is the horizontal, you can draw it from the X-ray line here, or you can even draw it above. So it will be corresponding. So sacral slope is a angle between the sacral slope and horizontal. So this gives us a prognostic value. So suppose there is a grade 2 listhesis. So if the pelvic tilt is more, so that is an unstable situation. So if the more your sacrum is horizontal and this hole is tilted, so this angle has increased. So there will be adjacent disease also because they are hyperlord. 1 minute, I follow is calling me continuously. So this is so to see the stability of the construct and to stability of the adjacent segment, these angles are very useful. So to know that pelvic incidence, pelvic tilt and sacral slope. I don't think that is a very huge topic like junctional kyphosis, junctional disease, adjacent segment disease. All these are dependent on these parameters. So you just need to know what is pelvic incidence. This is the pelvic tilt, and that is the sacral slope. So if you see a balanced pelvis, so low pelvic tilt and high sacral slope. So this is a balanced pelvis. So this would be an unbalanced situation. So if there is so slip angle is more, so pelvis is unbalanced. So you need to stabilize them, you need to fuse. So the whole assembly would depend on such issues if you identify these. So I don't want to confuse. I'm sure Dr. Agni will give a good lecture on this someday. Even I want to learn more on this. But you need to know these angles so that you are able to predict the prognosis of these situations in case of. So while planning a fusion, while suppose there is a grade 3, grade 4, in spondyloptosis, we used to plan these. So whether we want to do only posterior surgery, we want to get the whole thing, reduce it so that there is no adjacent. So even if you fuse this situation here, you will have an adjacent segment disease because it will be hyperlordotic. So that is what is the whole idea about these balancing. So we'll have probably a good lecture on this. So this is again trying to use this angle. This is the sacral slope. This is the pelvic incidence. So I was trying to draw this to make it. So coming to high grade listhesis, so there is a reduced area of contact. You can see here, this is the sacrum. There is the whole sacral surface, anterior surface, there is lysis there because this whole becomes trapezoidal. There is anterior border is long, posterior border is short. So there is very reduced contact. So even if you reduce it back, so the contact between the two will be very limited. So fusion mass has to be considered. Or if you do in situ fusion, they may fuse, but then you will have a very unstable situation about that. Is why the pelvic incidence angle needs to be. So you have to reduce the angle so that you will be able, there will no more stress on the L4, L5 this space. So that otherwise they will get adjacent segment disease, and then there is further recurrence of the symptoms. So bone erosion, all this, as I told you, there will be exiting L5 root tends to be directly over the L5. And so this root here, so there is, even in reducing that, you have to have a proper understanding of the whole situation where you decompress the both L5, otherwise you will get impaling of the L4 root. So you'll get more symptoms, post-operative radicular pain. MRI is a useful tool now. As I told you earlier, we used to have myelograms and scans, but now we have MRI. And with high resolution MRIs, we get good pictures where we see, can see spondylolytic defects as well as the adjacent diseases. Earlier, we would not be able to see the adjacent disc. So if there is a listhesis of L5S1, the integrity of the L4-5 becomes very important. Otherwise, they will have adjacent disease. So it's a very huge topic now these days. There are a lot of issues on this, a lot of papers on this. So that is a different topic altogether. So multiplanar views, ascertaining the disc and adjacent levels, dynamic flexion extension views will help you in that, and evaluation of the neural foramen. All this MRI gives you. So these are the diagnostic tools. So just a little bit about the adjacent disc. As I told you, there is, while to predict the future of a fusion, if you have done L5S1 fusion, what is the integrity of the adjacent disc also, or even the disc which is involved. Suppose there is a grade 1 or grade 2 listhesis or just a lysis. So what is going to happen in the near future, you can predict. So you have classification of this MRI disc degeneration. So you have one is homogeneous. You have a clear disc seam. There is bright white. It is clear. Distinction between nucleus and annulus is very clear. So you can see the annulus. There is very well demarcated nucleus. And then, so the height is also maintained. So it is a grade 1 disc. So grade 2 is inhomogeneous. You will see some irregularities like these footprints like there. The distinction is still clear, but it is hyperintense and isointensive cerebral spinal fluid. So there will be some changes there. And then height is still normal. So this is grade 2. Similarly, there's grade 3, then grade 4 when there is whole collapse. There is inhomogeneous gray, signal intensity is intermediate, and the height is also decreased. And finally, you have 5, where you have inhomogeneous black, lost, hypointense, collapsed disc space. So all this is classification. This is both useful as far as, so even in L5S1, if you have grade 5 disc, it is almost, you have a stable situation. So it is almost stabilizing this. So there is no vacuum maintained there. So there is chances of displacement, chances of deterioration are much less. So you may sort of ignore this. If there are no radicular symptoms, you have just collapsing of the disc, you have end-to-end plate contact, there is no mobility on flexion extension views. So all this comes in picture as you examine these and as you diagnose them. So whether to fuse this or you just do decompression, root decompression and do a posterior lateral fusion, all this comes into picture. And so it is very important that you know the integrity. Suppose you see an L4-5 disc, it is a tall disc where you see grade 3 intensity. So you might think of whether you should do something to L4-5 disc also adjacently. So all this has to be considered while, so you should know classification of disc degeneration on MRI. It's very useful in such cases. So T2 images are very useful. So even I, as a matter of habit, directly go to T2, although many people try to go serially T1, T2, T2. But in T2, it gives a very clear distinction. You can see the annulus here, then you can see the disc protruded out. So then you can see foraminal stenosis. This is a cyst here. So there is a, these are the telltale signs of listhesis. You can see posterior annulus, this posterior longitudinal ligament here, the posterior body is here. On an X-ray, you may not see this very clearly. So that is why the advantages of MRI is a boon now for present generations. I belong to an era where I seen MRI. Agni may not have seen this myelograms, but I have seen myelograms being done. We used to do myelogram, we admit the patient in the morning, do myelogram in the evening, and next day we used to do discectomy. So that is the boon of MRI. So you can see a lot of which you could not identify facetal cysts and all that. So now you can see that this is an unstable situation. Disc degeneration is there. So you can classify this as a type 3 disc. The above disc is also involved. So a very unstable situation probably, and with foraminal stenosis. So there's a lot of detail coming out of an MRI if you study it very nicely. So for a postgraduate student, it's very important to understand these, both the anatomy, as I told you, surface anatomy, as well as the radiological anatomy of these things, so that you identify, you are able to classify the whole disease and then prognosticate the whole process. CT, as I told you, is not very common, but in some situations, like in lysis or even in isthmic listhesis, you might be able to see. So it is called an incomplete ring. So you can see that there's a break in the ring. Normally, you'll see a single ring. So very useful in pseudoarthrosis, even in case of recurrent problems where you have failed primary fusions. So you will see this as a failed fusion. So you can identify it on a CT, or even in a discitis elements, you might need to do a CT to know this. Even pathological areas where you will need to see a defect in this, you will be able to do a CT. So should not close your mind. CT is still useful in many cases, and you should have that in your mind. Then coming to something called as tropism. Tropism is again, it gives you that so the facet. If you draw an axis on the facet, normally it should be equal. So the angle subtended with the central line. If you draw a midline in the canal from the spinous process, the angle should be almost equal. So that is a balanced situation. Both facets are well balanced. Tropism is when there is an abnormality. So this angle is 45 degrees, this will be 35 degrees, like that. So there is an abnormal loading of the facet. So they will start getting degenerative symptoms, and then there will be hypertrophy, then the whole thing starts. So that is what is also, again, and you can see in the MRI if you draw. So for PGs, it should be an habit. So see this. Once you know this, you will know the whole thing, because you draw a line. You may not draw a line, but imaginary in your eyes, you know that you can see that there is tropism, so you can easily identify that. So this is 35, this is 47, so tropism, so degenerative changes. It may be useful for prognostically, it may not be so useful, but as far as the audit or if your case is presenting the papers and all this, this becomes very important as a biomechanical tool. So this is the angle. So if it is tropism, it is mild, it is less than 5 degrees. If it is moderate, it is 7 degrees to 15 degrees. If it is severe, so it is more than 15 degrees. So that is again a diagnostic tool to know this. So purpose of imaging is this degeneration, as I told you, MRI, the adjacent disease, the present level, the involved level, as well as the adjacent disease you need to identify. Because now we are recurrence, things like this are not acceptable to the patient. So you need to identify. Earlier days, those were the legendary days where surgeon used to operate. After 1 year, they would come, they would think that it is God's act, but now that is not accepted. So you need to identify the whole process. So what is going to happen in next 5 to 10 years, you should be able to predict, and patient expects you to give results of at least 5 to 10 years of pain-free. So they ask you questions, because if you tell them that you have an adjacent disease and you are going to, there is going to be recurrence, at least you are aware of the whole situation and patient is able to take it. If you have not known only and you are not able to tell the patient, in 3 years time he comes with an adjacent segment disease, then he thinks that the whole, because they consider spine as a single element, it is not a each functional unit can be involved separately. So they think that surgery failed, so your surgery has failed. So, and if you have a colleague who is hell-bent on destroying you, they will say that that surgery has failed. So we should be able to identify and be able to know the whole process, the biomechanics of that functional unit as well as adjacent unit. So pelvic and spinal measures, you need to do these with these diagnostic tools. So radioisotope bone scan, flexion extension views, invasive diagnostic techniques like discography, all these are tools for diagnosis. So coming to treatment, only 20 to 25% require surgery unless you are like me who wants to operate everybody. Symptomatic listhesis is around 10 to 15%. Fail conservative treatment. So first choice of treatment still remains the non-operative treatment, because most of them, they have a natural history, like conservative care is effective, neurodeficit presentation more likely to need, suppose they have neurodeficit at presentation, so they may need surgery. Work related, if so somebody is like Mathadi workers, we have in New Bombay, we have a lot of Mathadi workers who are high labor class, they need to lift load, bend a lot, even workers, domestic workers, they need to do a lot of bending work, so they are not going to respond to conservative treatment so effectively as a person like who is a regular sedentary worker. So disc height, the taller the disc, like L4-5 disc is very high disc, means as compared to L5, as I told you, L5S1 is a stable disc because there is pelvis is surrounding it. So chances of deterioration are much less as compared to an L4. So if you see a tall disc with when the disc height is still maintained and there is grade 1 listhesis, the chances of that failing and deteriorating are much higher than, as I told you, in a type 5 disc where you saw the disc classification. So this is well settled, it is stabilized itself, and chances of deterioration are much less. And it is an L5S1 disc. So we should not rush to fuse an L5S1 disc unless there are neuro symptoms, there are radicular symptoms, or there is significant backache. In that case also, we should first identify whether there is L4-5 disc involvement, because they are usually more stable ones rather than L4. So L4-5 is, there are higher chances of L4-5 presenting more often than L5S1. So remember that, and while deciding the treatment. So risk of progression, as I told you, higher levels is much more. You can see here. So L4-5, although this disc space is also reduced, but this keeps progressing much more than lower L5S1 disc. So disc height, you can see this. As I told you, if you have a tall disc here, chances of deteriorating are much more as compared to this disc. You can see this is more or less stabilizing disc. Although this is listhesis there, but it may have auto-stabilized itself. You mean unless there is radicular pain, there is a lot of stenosis, canal stenosis, they may not deteriorate. So you can see. So this is the same patient progressively. So it is slowly stabilizing. You can see here, and finally here. So it is not deteriorated. The slip has not progressed. All the disc space has kept on settling down. So they will, more than the backache, they might come for you with radicular pain. So because there is settling, so foramen narrows, keeps on narrowing down, and they'll start getting pain. So don't rush, but as compared to that, if there is an L4-5, it is more chances of deteriorating. So this is a grade 3, grade 5, it has slip angle. So you can see there is complete disconnect between L5 and S1. And the slip angle becomes, so that is again, as I told you, these are the various angles you need to know. So what are the risk factors for slip progression? Growth, if it is an adolescent, they have dysplastic one, they are very high chances of they progressing. Girls have more deterioration than boys. Back pain, if there is a lot of back pain, that means there is a progression happening. So they are, that is a telltale sign. So there are chances of more progression if they are, and postural if there is gait abnormality. So hamstring spasm, hyperlordotic one types, there are chances that they are unstable ones and they are progressing. Radiographically, type 1 dysplastic, they are more chances of progressing. Vertical sacrum, as I told you, if the sacrum is vertical, more chances of more than 50% slip. If it is up to grade 1 and grade 2, there are less chances. But if it is more than grade 2, there are more chances. From grade 3 to grade 4, it is much So increasing slip angle and instability on flexion. If there is good opening on instability on flexion extension use, there are more chances of they deteriorating. So non-operative treatment, always considered first. So don't rush to the moment your patient comes to you. Although you know you are convinced that there are chances of needing surgery, you don't rush it. So give a trial. So that convinces the patient also, and that gives a lot of faith in patients. Whenever I see Dr. Agni's patient, I first convince them so that they stay with me. I don't immediately, otherwise they'll go back to him only. So always consider first, and every time you should try non-operative treatment. Improvement likely if back pain is more than leg pain. If there is a lot of leg pain, so chances are they will need surgery. Isthmic degenerative with leg pain, improvement is less likely. And investigate and treat osteopenia. So whenever you see, don't rush. First, see that there is no osteopenia, because if you're reducing them, if you're fixing them, stabilizing them, fusing them, see to it that osteopenia. So DEXA scan, bone vitamin D, and this, all these need to be done. So that is the time when you need to do or non-operative treatment. So don't immediately rush. Even if you see a grade 3, that doesn't mean that you rush to the surgery. You first treat them, always treat them non-operatively first, and then slowly you can shift to the operative treatment. So no neurological deficit, chronic stable deficit, as I told you, if there's a stabilization happening, you may treat them non-operatively. So treatment should be sufficient. And when you believe that there is a chance of non-operative, do it with a lot of passion. Don't just do it just for the sake of convincing the patient, but do it with, and if you find there is no relief, because they are very happy patients. If you're not given them non-operative treatment, they have stabilized and they are not symptomatic. They are very happy patients. They are very satisfied patients that they have been able to avoid surgery. Patient must understand, and then patient must understand the treatment. You get time to discuss with them the treatment. So improvement from patient's efforts to comply. So they comply with your advice. So always try to. So then there are associated components like fear of disability, narcotic addiction, litigation of potential secondary gain. For all these, you need time. So you need to sort of get them into confidence, plan the whole physiotherapy, then plan the surgery, give them the results of surgery, or your own patients, you might be able to convince them, improve the bone quality. All these things take time. So non-operative, what I mean to say is that non-operative treatment becomes a very important tool, even if it's a grade 2, grade 3 listing. So don't rush for surgeries, treat them non-operatively first. So what is non-operative treatment? NSAIDs, muscle relaxants, exercise programs, stretching and strengthening. I think we can have some physiotherapy session with these people, with a physiotherapist on a Zoom, so that they can explain the therapy program for such patients. So that is what I said. You should do it with passion, with the belief that they are probably are going to avoid surgery. Unless you have sort of compartmentalized that, as I told you, there is neurodeficit, there is severe back pain, they are not able to comply with the physiotherapy. So then you may shift to surgery sooner rather than waiting for a good physiotherapy to happen. So you can give facetal block. So again, if you have an adjacent disease, many times you will see grade 2 listhesis L5S1 with grade 1 retrolisthesis in grade L4-5. So these are situations where you need to do a lot of thinking, what is going to be, because the whole aim is that you fuse less functional units. So you try to keep a mobile L4-5 and only fuse L5S1. But it should not be at your own peril that within 6 months you will get symptoms at L4-5. So you need to plan these. So do facetal block, inject directly into the pars defect if it is a spondylolysis, whether his pain is because of the defect or it is because of any other degenerative change. So all these things need to, so think of all these modalities before you embark on surgery. So active spondylosis, again, as so they may get help with bracing, so for a short period of time, so that the defect heals if it's an acute fracture, or suppose, as I told you, some bowlers they get. So if you give them rest, give them bracing, they might heal. And traumatic fractures, if there's no underlying disease or any problem, they might heal. Or if there's no bony architecture defect from dysplastic types, then they may heal if there is just a simple fracture. So pain medication, stretching, beginning with gentle hamstring stretching, progression with additional stretches over time. So you can progressively keep on adding the exercise and see. Exercise that is controlled, and a good physiotherapist who understand the whole situation and the mechanical implications may be able to give a good program so that they get better. Particularly ones, as I told you, they are stabilizing types. So they have backache, they have certain lateral recess stenosis, but over a period of time, they sort of settle down and they might be asymptomatic for a longer period of time. So you can delay surgery or avoid surgery in such case. So spondylolysis, that is not healing or with with neurological, you might need to provide internal fixation and stability. There are different methods which we'll probably discuss in. So you can do past repair, the techniques. I'm sure we'll be talking later in some different. So I'll rush through this. So as I told you, activity and inactivity you can do by a scan or even by an MRI. If you see a lot of edema there and there is pain, so that means there is an active. So for PGs, I just want to tell them that you need to differentiate between an active. You might see a spondylolysis in many patients while screening. You might see in patients, but that doesn't mean they are symptomatic. So you have to prove that they are symptomatic. So that is how you see activity. So coming to isthmic, as I told you, stretching, trunk extensors, strengthening of the trunk flexors, especially lower abdomen, will help in these grade 1, grade 2 types. Posterior pelvic tick, flexing the lower lumbar spine from below and allowing them to maintain an erect posture. That can, particularly these IT people who sit a lot on the chair. So you need to sort of understand their ergonomics, so how their chair is. So they might be converted from symptomatic to asymptomatic if you give them good rehabilitation program, because they are young people generally and they have started get retrolisthesis or a grade 1 listhesis in such many cases. So you can sort of delay their surgery because you are ultimately fusing a functional unit. So if you can delay it for a longer time, so good ergonomics, how to maintain the tilt, how to control strengthen their abdominals and all that will help. A dedicated physiotherapist will be able to, in association with a spine surgeon, would be able to give a good program for such. And then selective block.
Abnormal neurology, and when sometimes when you have doubts, you can do positive diagnostic injections. So coming to indications of surgery, again, radiographic instability with symptoms. Document, when you have been able to, patient has been following up with you, there is a documented slip progression to greater than grade 2. For grade 1 and grade 2, you may observe, but if there is greater than grade 2, you can probably shift to...
The position
then symptomatic grade 3 slip, symptomatic grade 4 slip or spondyloptosis, all these need surgery. So contraindications, then there is a multi-level disease. When there are many disease levels involved, it is a very large area to fuse. You may not do surgery immediately. You may, actually there is no something, and I in particular believe that there's nothing like a prophylactic surgery that you, in degeneration, that you feel that there is a disc which is going to degenerate in next 3 years. So you don't fuse that also. So you try to preserve as many functional elements, functional units as possible. So in such cases, you may still do rehab, you may give bracing, you may avoid surgeries if there's a multiple level disease and you are going to fuse the whole, you need to fuse the whole spine. So poor patient, although many surgeons may disagree with me, but I would rather wait and watch such patients and see that if I can avoid surgery in such patients. So poor patient motivation or compliance, if you are sure that, so particularly as I told you, in such patients, you may even need to do a lot of psychoanalytic studies like Minnesota score and all that. So see that how is their motivation, what is their response level going to be, because otherwise these are patients who can be of a lot of trouble to you as far as litigation is concerned. So see to it that there is good compliance, good understanding, good motivation of these patients for surgery. Very low level activity level. If they are not very old ladies who are sitting at home, hardly moving from one other, you may avoid surgery. Osteoporotic, you need to build them up. And so all these patients, you may avoid surgery. And tobacco use is a very important. There are lots of tons and tons of papers coming now where there is a lot of chances of pseudoarthrosis, failure of fusion, failure of implant failure in case there is habitual tobacco use. So always ask the history of tobacco use in such patients, and you may avoid surgeries in such cases. So surgery, the basic element is decompression, where if there are a lot of radicular symptoms, central canal stenosis symptoms, so you need to do the primary gold standard in such cases is decompression. So degenerative listhesis, hypertrophic facet joints, thickened capsule, as I show you, the cyst, facetal cysts, all these they need because they are impinging on the roots, impinging on the canal, they will need decompression. So decompression forms the hallmark. It is the central pivotal point on which the surgery depends. So you need to do good decompression. the whole lateral recesses as well as the central canal, and then that itself gives you good results. In good old days, we used to do only decompression in such cases, what is called as I'll come to that. So dorsal, that's called as Gill's procedure, but I'll tell you that later. So dorsal approach is the still the gold standard, at least in our part of the world. Dorsal approach is the most common approach, which is done in these cases where you do decompression. So isthmic spondylolisthesis, so you can do decompression, and then there's something called as floating fusion. So you may do just grafting of the intertransverse joints. So they may not actually fuse, but there is some amount of constraint provided by this fusion mass. So it doesn't allow the progression of the slip. This is called as floating fusion. These surgeries were done in good old days, where they would do good decompression. So they would have good relief immediately, but over a period of time, they may deteriorate, the slip may deteriorate. So you would add intertransverse fusion in this. So that's called as floating fusion. So, but now we do, with advent of the instrumentation techniques and evolution of the understand, as I told you, of these biomechanics, we are now able to give good fusion mass and then able to fuse these. So coming to Gill's procedure, as I told you, if you know, in listhesis, where, as I told you, the pars interarticularis breaks, so there is a free floating laminar fragment. So the whole lamina, the butterfly posteriorly, the two lamina on the both sides from the pars inter, they are floating, they're free. So it's called as it's like a free fragment there. So we just remove that. It's called as rattle. It is like it is moving around there. So you just dissect it and then you can remove it. So that gives you good decompression posterior if there is central canal stenosis, as well as some amount of lateral recess, although you need to do foraminal widening also in such cases. So it's a very simple procedure, half-an-hour procedure. You just remove the whole thing, you decompress it, and then I told you, you can do some intertransverse fusion, put some same bone. We used to make it small pieces and then put it in the intertransverse area to provide a floating fusion. So that would prevent further deterioration, but there would be a very high percentage of patients where deterioration will occur. The slip would progress and they will come back to you after 1 year, or maybe they may not even have relief of back pain in such cases. They will get good radicular relief, but their backache will still persist. So you end up giving them braces all the time. So, but you have a mobile segment anteriorly. The disc, you don't touch the disc, you just remove it. So you have a functional unit. So there is mobility there at that level. So this is contraindicated in younger patients. So you can't do this in younger hyperactive patients, young patients who will deteriorate obviously very commonly. So then there came like something like in situ posterolateral fusion. So as I told you, so it is a more refined thing of floating fusion, where you actually bar the whole transverse processes, the lateral masses, the lateral part of the facets. You don't remove the facets completely. So you put intertransverse fusion as well as the lateral, you put it on against the body. So it's called as posterolateral fusion in position. So L5 S1, it is very adequate because you have the arch of the sacrum there, lateral mass of the sacrum. So it provides a good base. So you can fuse them. And as I told you, L5 S1 is a stable level. It is not so mobile as L4-5. So you have pelvic bones on both sides, which provide some amount of constraint. So they don't deteriorate so fast. So in such situation, L5-S1 fusion, it would work. So there are a lot of papers where it is adequate, the posterolateral fusion. So even now we do L5-S1, we may do instrumented posterolateral. We don't do interbody fusion. We don't disturb the disc. We just decompress the roots, put pedicle screws in L5-S1 and then do a posterolateral fusion. So it is a simpler procedure, faster procedure, and you don't go to the disc. You don't disturb the anterior column. So there is good relief in anterior improvement in leg pain, neurogenic pain there, and even if when you stabilize them, so because there is no stretch on the roots, so they may, even with, if you have not done an adequate decompression, they may still improve in leg pain. So this is called as posterolateral fusion. Then the conventional posterolateral fusion, it doesn't many times work, as I told you, in L4, L5, where you have transverse processes and then there's no adequate bone, there's no bone bed. You just have two small flimsy transverse processes where you can't put good grafts, so they may not fuse. There will be failure. So chances of pseudoarthrosis is very high. So very little surface fusion bed. Graft is under is placed under tension. So as there is mobility at L4-5, so it is always under tension. While L5-S1, there is a large bed, pelvis is stable, so it is not constantly under tension. So there is low fusion rate at L4 higher levels. So elongation of fusion mass. So the fusion mass may keep on elongated. That is what is called, again, a floating fusion type of thing. So it will be some amount of gumminess, but then it is not a full stable fusion there. So then there will be compensatory postural changes and to remain. So when there is instability persisting at that level, so the if you have hyperlordosis at L4-5 or L3-4-5, it will persist. So you will not get a good posture back. So which is a very important sequel of a good fusion. So once you're good, you get a good fusion mass at L4-5. So there is no stress on L3-4. So you'll get a good posture, erect posture. So that biomechanics is restored back. So all that is, so that is why we have moved further to instrumented fusions. So in degenerative spondylolisthesis, it is identical as for lumbar stenosis. Laminectomy along with posterolateral fusion is, as I told you, in grade 1, you may do posterolateral fusion where you have done good decompression. Your foraminal are maintaining a good height. You don't need to go very laterally to cause more instability. So you may do posterolateral fusion, and that will itself stop the progression and stenosis. And pedicle, it may be done with pedicle screws. So you get a good fusion mass in such cases. So technical, as I told you, there is abnormal neuroforamen. You need to do a lot of decompression of the foramen. Geometry may be confusing. So there is a lot of hypertrophy of this fibrocartilaginous tissue. So you'll not be able to identify the structures very nicely. There are thick fibrous bands going around. So so it is very difficult anatomy there and there. So to free the nerve roots is very tough. So in very high fusion slips where there is grade 3, you might do in situ fusion. So you may have a fusion mass which is not under compression. So it is under tension. So again, you have almost an L5, L4 transfer or L5 transverse process, which is lying almost in a horizontal position as compared to S1. So because there is grade 2, grade 3 slip. So the transverse process is much ahead. So it is not in a vertical position. So fusion without decompression, very rarely we need to do fusion like these MIS people now. I'm sure Dr. Agni Shekhar must be doing it, where you have just a lot of back pain. They have no radicular symptoms. So you don't need to do good decompression. So particularly in MIS, the skill of doing decompression of the opposite side over the top, and it is difficult. So some situations where you know that there is just slip, there's not much neural element involved. So you may do just fusion without decompression. So you just do percutaneous screws above and below, then put a fusion mass posteriorly through the same tube, and then you get a good fusion. So that is also a possibility, but not very commonly seen. Then coming to what is the most common surgery which we do is full fusion in instrumentation, where preservation of lumbar lordosis and a high fusion rate is needed. Patients at risk, smokers, where you need, as I told you, in smokers, you need to avoid. And there are papers where they have presented that fusion, instrumented fusion gives you much more chances of fusion, rates of fusion as compared to where you don't do instrumentation. So that is why now more and more people are doing instrumented fusion as compared to an uninstrumented fusion, as I told you, posterolateral fusion. So most of the times we do posterior instrumentation. So pedicle screw above and below, and then put an either a posterolateral fusion, only intertransverse fusion, or many times you do an interbody fusion where there is all the 3 columns are stabilized. The anterior column, the middle column where you have the pedicle screws, and then the posterior column where the rod is stood. So you do more or less a global fusion in such cases. So you can see here, this is a sort of an instrumented posterolateral fusion. We have not put any interbody graft there. We just put some cancellous bone. We may not touch the disc, we put cancellous bone in the intertransverse area and just fuse the whole area. You are not able to restore the height of the foramen. So many times if there are neural events, neural compression is there, radicular pain is there, this may not be so satisfying a procedure for such patients, because you have fused it, you have got it, you have not restored the height of the neural foramen. But it is a, if there are not radicular symptoms, this may work. So this can be done both percutaneously as well as you can do it in open technique. So as usual, you can put one screw above and below. You can see, you can do complete decompression of laminectomy, or you can do, if you have not much radicular symptoms, your foramen are not very tight, you may do just on one side and then just decompress the foramen on both laminotomies, and then do a sort of a pedicle, pedicle screws, either MIS or open techniques. Complications are malposition implant. If your implant is not in good position, infection, blood loss, and CSF injury. This dural leak sometimes can be injury, because you are doing a lot of, if you have to do anterior interbody fusion, then you need to do a lot of retraction. Many times the root in the axilla is avulsed, so you do a lot of dural leaks. Then pseudoarthrosis and implant failure is, although now we have a lot of good implants available where you have, there are earlier, because there was, I will show you, I think probably one or two x-rays. When I was in my early days of my career, we had those pedicle screws with Steffi plates, where instead of rods, you had plates. So they were screws who had a diameter, but the junction of the interface at the proximal part of the screw and the posterior part of the screw, there was the weak area. So they would break. If your fusion has not occurred between L5S1 or L4S5, the screw, the whole load was on the screw. So the interface between the narrow part and the broad part of the screw was weak, so they would break. That is why the present generation screws are, which are sort of a conical screws, where there is, as you go towards the end of the screw, they are thicker, wider there, while at the tip they are little narrower. So they are like cone. So they have good hold on the pedicle as well as, and they have good strength. So they don't fail. Even if your fusion has not occurred, they may not fail. Your screw may come out through the end plate, but it will not break. Earlier, we used to see a lot of breakages of the screws. So asymptomatic, pseudoarthrosis may be symptomatic or asymptomatic. It may be because of anemia, osteoporosis, right? If you have not done good preoperative assessment, bone scan, vitamin D assessment, so you may get failure of these assemblies. Tobacco use is a very important cause of pseudoarthrosis. Coronal, if you're, as I told you, in high degree of listhesis, if you're not able to get a good restoration of the reduction of the proximal vertebra on the distal vertebra, you may have a lot of stress on the implants as well as the interface of the bone and the screw. So you may have failures. Horizontal oriented fusion mass, as I told you, in high grade listhesis, there are chances of failure. So levels of instrumentation, that is what we need to do with an MRI to see that how many levels are involved, what is the disc change in the adjacent segment. So before you fuse the level, you have to see that adjacent level is not under stress, it is not going to fail. So look at the changes of the level. So that is why disc classification is important. So take good assessment of the MRIs, see your MRIs, assess them quite nicely. Do whatever it takes. You do bending films, you do good MRI assessments, and you can even, as I told you, can do discography if you want to see the integrity of the adjacent disease. So you need to restore, say that what levels you have. So it is most important that you don't fuse levels. So don't do prophylactic fusion. That it is going to happen in 6 years, so you fuse it now. Try to give a mobile spine. Try to preserve, because otherwise we have as I told you, the junctional disease, the adjacent segment disease is a very big issue now. A lot of research has been done on that. A lot of research has been done on the biomechanics, how it is going to function. So earlier, as you can see in this X-ray, earlier we used to do, to get a reduction, we used to do 3 levels. Now we don't do this. If you can see this now, although we have not been able to restore the reduction of L5-1S1, but to get that, we used to take anchorage on a normal level above. So we used to pull the whole thing up. Now we have techniques where we can do it on the same level and yet preserve the upper level. So we don't do this now. I'll show you the slides for this. So, so sometimes we like here, if you have an L5S1 which is reduced, but you have a listhesis at L4-5, you can get away with this because you don't need an interbody fusion at L5. As I told you, it's a stable level. It has the both sides the iliac bones protected. So so you do an L4-5 interbody fusion, while you can get away with just a posterolateral fusion or an instrumented fusion of L5S1. You don't need to do 2 levels, so increase the morbidity, increase the chances of neural injury. So you just do laminectomy or a laminotomy at that level and just do instrumentation there, while at the higher level, which is the unstable level, you do a good proper job of 360-degree fusion. So all these permutations and combinations you have to see with a good assessment of the preoperative assessment. So to know that what exactly you need to do. So coming to interbody fusion, earlier we used to do posterolateral interbody fusion. So interbody fusion, as I told you, is a sort of a 360-degree where you do anterior column stabilization, middle column is stabilized with pedicle screws, and posterior column you have the tension band there in the form of a rod or a plate earlier. Now it is a rod. So you can see this. So it gives higher chances of all the papers mentioned that you get much more chances of union in such cases if you do an interbody fusion. But in such certain situation, as I told you, you may get away with only posterolateral fusion if it's a stable level L5S1. But in L4, L5, you generally tend to do an interbody fusion. So that is PLIF, posterolateral interbody fusion, where you go on both sides, you retract the roots and go to the axilla of the root, and then prepare the bed, graft bed, as you do in TLIF. In TLIF, you go lateral to the root. You go from the between the two facets, you create in the neural foramen, you enter it through. So you don't disturb the central area. So you go from the lateral to the medial side, where here you go directly, you retract the cord, you retract the root, and then go it through the axilla of the root, and then put 2 cages on both sides. So this was the initial beginning, what was done. Now we do what is called as TLIF. So this is what is PLIF. So we used to put 2 billet-shaped cages on both sides. In initial years, when the cages were not present, available, we used to do iliac crest grafts. We used to fashion them in the same shape, and then we would retract the cord. In fact, we used to put a roller pack, a thin roller pack around the cord, lift it up, put bone graft, punch it in, put anterior in the anterior sort of longinal ligament. We used to put cancellous graft, and then punch the iliac crest grafts, dowels like thing, like same thing, but iliac crest, and then put it both sides. And so we have bone-to-bone fusion, and then put instrument pedicle screws. Then cages came. So these could be, instead of grafts, which were sometimes loose, sometimes very bigger, they would break. So we had no control over the thickness. Now you have tools where you have instruments where you can measure the interspace and then put the cages according to the same size. So they can be lordotic cages where you get 5 degrees lordosis. So you can get because as I told you, to restore the biomechanics, you need to get the lordosis back. You need to get the height back. So to get that, you have different configurations of the cages, which in iliac crest was very difficult. You would spend a lot of time in refashioning the graft. So that is why that technique was given up. And so you had PLIF. Now even PLIF is remained, because to retract the cord, many times you would injure the axilla of the root, or you in chorda equina like L3-4, L2-3. If you want to do PLIF, it was very hazardous because they have chorda equina. So you can't do PLIF near the chorda equina. So that is why there we started getting. So this is just an example of PLIF. These are different cages. You need to put 2 cages. So you need to go both sides. While in TLIF, we may not go to the opposite side. We just put a cage which is in oblique direction, and it would give the same results to you. And if you have on MRI, as you have studied the MRI very nicely, you know that the opposite foramen is not so tight. So why need to do facetectomy on that side and then put a PLIF cage? So you would do. But in PLIF, we could not. We need to put generally, and an ideal technique would be have 2 cages inside. So that is why this technique was later more or less given up. So this was, we used to put mesh cages. You can see that small mesh cages refined. But they were very difficult procedures to get that cage into the body, retract the cord, a lot of injuries. So we have injured a lot of roots They would get avulsed from the axilla. And then, but as I told you, these were legendary times when patients would still handfold you and touch your feet. But these days you can't get away with these procedures. That's why the techniques have refined, the things have evolved, they have become easier, they have become much better. So you have good instruments. So you should have knowledge of good instruments and good access to these instruments. So your results are definitely improving. So then comes TLIF. As I told you, you do cut the facet, go lateral to the root, and you can go through the axilla also. And so you are not directly retract. In fact, in TLIF, you hardly need to retract the cord. So you go lateral to medial. Your access is from the lateral to medial, and this you can see. You can put the opposite side screws and close that, and on this side you can remove the rod and do the TLIF work from this side. So you prepare the bed above and below, and then you can put the graft, as you can see in this. So you have bed available there. So on the other side, you have not disturbed ligamentum fleum, so you can put a good graft on the a normal side, while on the TLI the side you put the cage, the foramen which you want to widen up more, the root which is more involved, that side you can access and do a TLIF. So transforaminal lumbar interbody fusion, it is you access from the laterals to the facet or through the facet. You don't go medial to the root, you don't go need to retract the cord, you directly access from the lateral side. You can see the trajectory. You first put it in a more this oblique position, then you can push it a little bit and get it into more horizontal position. So that is the TLIF. You can see and these are peak cages. There's a polyethyl ether ketone cages which are radiolucent, but you have these small dots which are available seen, which gives you the length and width of the graft, the cage. So you know that which is the posterior. If you see the posterior dot, you can see that is the posterior edge of the cage, and the anterior dot is the anterior. So you know that it is not impinging on the canal. So you have a good, you can see the fusion mass now, the whole bone is consolidated. While if you have the metal cage, you may not be able to see the fusion mass. So you are always depending on the clinical symptoms of improvement. So here you can see that it is fused. You can very confidently say that it is fused. The lumbar lordosis is restored. So you have good alignment. So the above disc is not under stress. So it's a good result. So interbody fusion can be ALIF if you get through the anterior. So many times in L5S1 disc, you may go, because in Western countries, in Korea, I have been there, they used to do a lot of ALIFs. It's a way, almost a minimally invasive technique. They would go through the anterior abdominal wall. Patient is in the lateral supine position, then they approach. So it's a minimally invasive. They just and develop the space between the bifurcation and then put an ALIF. It's a good stable construct. You can do a good job. You may not be able to see the canal very nicely, but then if it is just a fusion to be done, you can do ALIF. So, but I don't think in India it is so common, because we can do a good job through the posterior. So that is ALIF. Then there is, as I told you, TLIF and PLIF, the trajectory you can see. And there is now something which is coming, becoming a vogue, is what is called as XLIF. So it is through the lateral portal. So if many of you, I don't know whether we have discussed approaches in this seminar, where we do retroperitoneal approach. So you go through the patient is in the lateral position, you approach through the abdominal wall, you retract the peritoneum anteriorly and then go to the lateral surface of the spine. Like in Cox, we used to do a lot of decompression, putting anterior grafts there. So you are anterior to the psoas, you have psoas which is lying on the lateral surface of the you can see the body here, and then the part of the transverse processes. So you go either through the psoas or you go anterior to the psoas. So that is called as XLIF. So that is a new approach which is being done, and we do fusion through this level. You can put a cage, horizontal cage through this level. Again, a stable situation. You can do good decompression from there anteriorly, and you get a good fusion mass. And TLIF, as I told you. If you want me to stop, I can stop. Agni, if it is too long.
No, it's okay, sir. Let's ask
So
the participants what is their preference. Means they want the other part to be taken in separate lecture, or
So I don't know if nobody is responding. I hope there is. But anyway, I will finish very soon. Then that was the fusion. So now reduction of listhesis. So you need pedicle screws, you need a spinal frame, you need restoring lordosis, you need improved bone contact. So I am a firm believer of reduction. Many people do in situ fusion. They put screws in the position and they don't convert grade 2 to grade 1 or grade 1 to grade 0. I am a firm believer of reduction. I feel that you should get a good reduction. So biomechanically, there's a more stable, more satisfying situation. There is less chances of junctional adjacent segment disease. So you need to get good bone contact. So to improve the load bearing capacity. So you do interfusion fusions in such cases become necessary. So as I was telling you in earlier days, we used to get a good reduction. As I told you, I'm a firm believer in reduction. So I was always interested in reduction. So reduction can be done through either with a reduction screw, or you do a good release and then try to pull it up with a reducer and get it up. So, but in those days, we used to get a firm anchorage in the above vertebra. You can see here is a grade 2 listhesis. So do flexion extension x-rays. Can see the mobility there, not much reduction on extension. So on table, you need to reduce it. Okay, so this is the MRI. You can see the pseudodisc there. So you need to reduce it. So this is what we do. We under C-arm, we put L4 screws. L5 is reduction screw. Here we have not put the reduction screw. We get reduction. So S1. There is a lot of science in these. I don't know whether I'll be able to cover that. Like S1 screws should be bicortical screws. You should get the hold into the anterior cortex, while in rest of the vertebrae we don't. We do go up to the 2/3. So L4 screw is only up to the anterior 1/3 and posterior 2/3 junction, while L5 S1 screw you should go right up to the bicortical. So bicortical approach is the best approach in case of otherwise they might have a pull out, because your S1 screw is a very base of the whole assembly. So if you want a good reduction, you should have a good hold on S1. So that's why it should be a bicortical screw. But even tricortical, sometimes people prefer to put a screw which goes from the posterior part to the sacrum and then through the anterior disc space, go through the disc space. So that is almost tricortical screw. So here we prefer only because the bicortical, there are very remote chances of injuring the vessels. So you feel that you drill to the anterior cortex, and then with a large probe, you might just breach the anterior cortex, and then your whole screw goes anteriorly. So good hold of in the sacral screw. Then as you put your rods, you put a reducer on this, you can see here. So you can see here, and then pull the whole thing up. So the whole thing, so instead of the reducer, we may put a reduction screw. So if you have seen reduction screws, they have a long tube up where as you tighten them, the whole vertebra is pulled. But this is very important. This technique is you should have a good hold on the screw. For a good hold, you should have good bone quality. So for good bone quality, you need to do a preoperative assessment. So do a good DEXA scan, see that they are built up. You might, many times we need to give teriparatide or to build up their bone quality. So before we embark on this surgery of reduction, otherwise you may do in situ fusion in such cases. So if you're going to do reduction, see to it that your bone quality is good, your reduction hold is good, your screws are in proper trajectory and in proper hold. Hello, are you hearing?
Yes, we are able to hear you, sir.
Yeah. Okay. Sorry, somebody was calling me. Anyway, so once you have got here, as I told you many times, because the hold used to give way, so we will not be able to get a good reduction. So then we do almost same situation. But here we have taken, as I told you, we have taken a hold on the disc above. So many times we used to remove that, or we used to keep that. So that is all now because of good techniques and good. And besides, as I told you, besides the hole, you need a good dissection. So you need to go very laterally, disengage the whole, what we call as skeletonize the L5 vertebra. So go very laterally, disengage the whole fibrocartilaginous tissue so that the whole vertebra is very loose. So this actually trained us to do spondyloptosis, where we used to get good reduction. So that is, here you can see the cage, and that is, we have not got a grade 0 here, but grade 1 we have accepted and we have fused it that way. So that is ultimately, so you can see post-op here. So this is not now needed. We don't do this now. We don't get a hold on 4 unless there's a disc degeneration there or there is chances of adjacent segment disease. We do only L5S1 or L4 single level, single functional unit fusion. So this is again a grade 2 listhesis where we have jacked it up and we have put a bean-shaped cage. Again, bean-shaped cage we don't put now these days. Many surgeons still prefer it. But I don't know, I have not seen Agni also using bean cage. It is not, now we have these TLIF cages, which we put obliquely. One cage is good enough. We don't, this was given to be increase the surface area of the fusion, but we put a lot of implant there. So it was found that fusion rate still remains the same. So if put a singles, you need to tilt this cage very nicely to get it into a good alignment. So that is why this was not, has become very popular. So one slide about the reduction. Again, if we are doing single level, as I told you earlier, we used to put higher vertebra hold to get this, but now we don't do. So we do meticulous exposure of L4, 5, S1, entire intervertebral L5 disc is removed. As I told you, skeletonize the whole transverse process tip to tip. We completely disengage the L5 from S1, remove all the fibrocartilaginous tissue, flatten the dome of S1, disconnect the L5 and S1 vertebra as completely as possible. And then we put screws, visualization. I'll just rush through reduction of in screws in L5 pedicles. We may put reduction screws in L5 pedicles to get reduction, or you may use a reducer if you have a good hold. So sacral pedicle, as I told you, is entered in a slow incremental fashion. Anterior cortex is penetrated. As I told you, we need to get a bicortical purchase on sacrum, because sacrum is the scaffolding on which the whole assembly works. If you have good hold on sacrum, then you can get a good reduction. Largest diameter polyaxial screws in put in S1. The entire intervertebral L5 disc is removed. Disconnect, as I told you, that you do. So then reduction maneuver is tighten the S1 screws, partially tighten the reduction screws, distraction is done. So we do a railroading technique. We distract it, don't tighten the L5 screw, we distract it, and it automatically, if you have contoured the rod well, it automatically, the L5 is reduced. So it pulls up the whole L5 vertebra, then distract it fully, and then we loosen the sacral screws. I don't know whether that is here. So this is again a TLIF. You can see reduction. This is the fusion. Again, a beam cage used. So this is what I was telling you. In high L4-5 disc, where you have a tall disc, if you just put pedicle screws and you have not done a good fusion, you have not done an interbody fusion, they will ultimately fail. Unlike L5-S1, which is a more stable disc, you might get away with just posterolateral fusion. But if you have an L4-5 disc, which is a tall disc, which is not stable position of stabilization, you should put an interbody fusion. So you should always put a cage in such situations. Otherwise, your assembly may fail. Then while getting reduction, you should see to it there is no segmental kyphosis. So you might fuse it, but then there is segmental for your upper disc is still in stress. So you might get adjacent segment disease. So because if you can draw a line on the posterior border of L5 and S1, you'll see there is kyphosis. So although you have got good fusion, but there is segmental kyphosis. There is a lot of hyperlordosis on L4 disc. So chances of getting adjacent disease is very high. So again, this is a very old X-ray where we have used Steffi plates. You can see this, there we have put cross links. Those days we used to try to get as much as stability as possible, but now we have good screw holes. You can see these screws, they are like cylindrical screws. They are same diameter from front to back. And these are there. So they used to fail at this junction between the washer and the plate just below that. So they used to break. So if you have, this has not fused, so they would fail. So if you have not done an interbody fusion, they would fail. If you have not done a good, your pseudoarthrosis has developed, they would fail. So that is why we do good so this is where we have put iliac crest grafts and packed it. There was no cage those days available. So then we used to get, but again, because it has deteriorated. The interface between the screw and the bone has the screw has loosened up on the bone, the hold is lost, so it has developed into a kyphosis. It has moved for, it has fused luckily, but there is development of kyphosis. So again, that is when you are doing a reduction technique, you should get good restoration of the lumbar lordosis to prevent adjacent segment disease. So again, few examples of fusion with the, this is the beginning of the T-leaf, where we have put a T-leaf cage. On the left, you can see a bean cage. On the the two sides, you will see a T-leaf cage, where a single cage in an oblique direction is put. Again, example of PLIF, where two mesh cages have been put. So this is one more example of iatrogenic listhesis. You can see this was some discectomy done, laminectomy done. It has started, tried to stabilize, but there is a attempt to auto-stabilization in the front, the disc space reduction. So they develop lumbar canal stenosis, foraminal stenosis. They come back with the neurogenic claudication. So there is a lot of fibrous tissue around the roots. So you need to do an open decompression again, and then obviously stabilization also. So you can see bending films, not much movement, but there is a lot of neural element involved in this and some amount of instability. So you need to do good decompression. You can see MRI here. This is a recurrent stenosis post-laminectomy. You can see there. So you need to increase the height. So you need to, because there is foraminal narrowing, so you need to increase the height. Here, because it was not a very mobile, we have, I think we have put a cage. I think there's a cage inside, and then grafting to increase the height, neuroforaminal height, and TLIF done in such cases. So in such situation, as there is not a high grade of listhesis, you don't need to do reduction. So you may do a laminotomy on both sides. As you can see, the interspinous spinous process is maintained, and then you go on both sides, decompress the roots, and then put a cage on T-leaf on one side. You don't need to go opposite sides. So as I told you, in TLF, that is the advantage. In PLF, you need to go at both sides, because you need to retract the cord and then put the cage on both sides. So finally, this is spondyloptosis, where there is complete disconnect. So this is a pre-op. You can see the L5 is trapezoidal. This is lying anterior to the sacrum. So we need to, as I told you, I believe in reduction. While many surgeons can do in situ fusion here, there are many techniques. I think that would be a different topic, where you can put screws from S1 to L5 and fuse it in situ and do decompression. But as I told you, I believe in reduction. So this is stage 1, where you go anteriorly. This is the vein, common iliac vein. You can see this is retracted. And then you can see this is, if you can, I don't know whether I can get the pointer. I'm working on the phone. You are seeing the disc, which is the white glowing structure between the vein is the disc, and below is the bone. That is what we have excised. So below, that is the trapezoidal part of the L5, which is excised completely, and below that is the sacrum. So all that is removed, and then we try to get bone-to-bone reduction. So that is stage 1, when we go transabdominal, either through the retroperitoneal approach or through the transperitoneal approach, and excise the vertebral part, which is in front of the vertebra, what is called as Gaines procedure. Gaines procedure is when you remove the whole L5, which, if you can go back here, you remove the whole L5, which is anterior, and then get L4 onto S1. So that is called as Gaines procedure. So this is something similar to that. Here we have not removed the L5 completely. We have removed the part which is below the sacral promontory. So we remove that and try to get an L5 on S1 fusion. So you can see here, this is the posterior stage 2 now, where we have gone posteriorly. This is the cord completely exposed. The roots are exposed. Patient is turned prone, and then we do fusion, good fusion done posteriorly. So this is the reduction. You can see L4 screw is there. L5, we have tried to put in the remaining part of L5, which we have tried to reduce, and S1. So this is a modification of the Gaines procedure, where we try to get bone-to-bone contact. That is L4 on L5 Gaines. But chances of neurodeficit in that are much higher, because you are overcrowding of the roots, because you are collapsing the whole column. So in our case, we try to present it at bone-to-bone L5 on S1. So with decompression of the roots, so chances of neurodeficit are less. So this is the fusion at 3. This is ulta. If you can see it, somehow it has got. So you can see there is a good fusion mass between, although there is some deterioration of the reduction, because as I told you, the bone hold may not be good. So while tightening it, or even the post-operative period, they may slightly deteriorate, but still it has finally fused because it is bone to bone. So if it is L4 on S1, there are chances of failure much higher. In our case, although it's not a very large series, so we try to bone to bone. So that is all. Thank you very much. This is Tiger Woods, who has undergone fusion surgery. And so results of fusion surgery, as I told you, they have improved considerably now. I can see excellent results with fusion surgery, although earlier we had a lot of failures in such cases. But now the techniques, the instruments, everything has improved so considerably, and the surgical skill has also improved because now the things have evolved and moved forward. So you can get good results. So this is him after the fusion surgery. Thank you very much. Any questions you can ask?